So now it's a great privilege to introduce our next speaker. And our next speaker is Professor Sunny Anand. And you're Professor of Pediatrics and, as I understand, Pediatric Critical Care, Perioperative and Pain Medicine at Stanford, California. Professor Sunny Anand is a translational clinical researcher who really pioneered research on the endocrine metabolic stress responses of infants undergoing surgery and developed the first ever scientific rationale for pain perception in early life. And this has provided a framework and an initial basis for newer methods of pain assessments, numerous clinical trials of analgesia anesthesia in newborns, infants, and older children. Very welcome.
Thank you very much, David. And thank you for that wonderful talk, Morten. I feel like, someone who has to talk about morality after Moses. But my topic is different, and I hope it'll create at least half as much sense as what Morten achieved. Preventing pain and promoting wellness in newborn babies. And this is more about wellness than about preventing pain, because I know others, my friend Elizabeth is going to talk about pain management in more detail. So here's I grew up in Calcutta, and I met Mother Teresa as a young child. And in 1971, there was the India-Pakistan War, and there was a protest against the war. And so she said, I don't participate in anti-war demonstrations, but if you have a rally for peace, I'll be there. And this is an important distinction. The two are very different. The energy of no war is the energy of conflict. It adds to the hostility and so on. And whereas the energy of peace, as you can see in these two demonstrators, is very different. It's one of, let there be peace, let there be, mutual coexistence. And in healthcare, unfortunately, we have focused for almost 100 years on the global burden of diseases. But the big question is, what about wellness? Less and less, and I am so happy that Professor Kringelbach has established this Center for Eudaimonia, and I think that is essentially one of the ingredients of wellness. So when we go from I to we go from illness to wellness. And the path going from I to we is through love. So that's my hypothesis, and I want to, perhaps convince you to some extent. Not the way love is conceptualized as in terms of physical relationships, but love simply for the sake of love. Love that comes when you see a little puppy or a butterfly, or that is, the kind of the true love. And I've talked about this in a different article. This was, published about 15 years ago, where I talked about love, pain, and intensive care, being an ICU physician myself. And even today, after 35 years of doing this, I still have a lot of joy when I'm working in the ICU. It's tiring, but there's no activity that can compare to that. And certainly my spiritual mentor, has encouraged the yearning for a chance to console, comfort, encourage, and heal. Seeing ourselves as the other, that is the barrier we need to get over from I, me, and myself to go on to. So let's talk about pain and defining pain. This was an article published a few years ago in Acta Pediatrica. And I was really inspired to write this article by the words of Peter Nathan, where he says, ideas need to be fruitful, they do not have to be right. And curiously enough, the two don't go together. So talking about pain and pain management, this is the analgesic ladder, where a baseline consists of avoiding painful procedures. Then come some of the non-pharmacologic approaches: sucrose, glucose, breast milk, and then topical anesthetics and creams, the non-opioid analgesics, then opiates. And then finally, we have more invasive ways of through nerve blocks, caudal or epidural anesthesia, and finally to deep sedation, general anesthesia. So this has been published, and I'm sure will be talked about in various different ways. What the baseline should be is to reduce the number of painful or noxious events that the baby is perceiving. And there's many ways to do that. Unfortunately, the nice markers I had used for bullet points got changed from Apple to PC. So anyway, I think clearly we're doing this in the NICU to anticipate, minimize blood sampling, use sort of venous or arterial line placement, avoiding heel sticks as much as we can, other non-invasive monitoring, and so on, other ways of providing the care we provide in the NICU without causing pain. There are various non-analgesic approaches. Many of you are experts in these areas, and I've learned a lot from your writing and your research about non-nutritive sucking, about facilitating tucking, kangaroo care or kangaroo mother care, support for sleep-wake cycles, presence of the parents at the bedside, breast milk or breastfeeding, sucrose and other sweeteners, and then going on to the other things that we talked about. So just as a summary in terms of how do we approach preventing or managing pain in babies, is first avoiding, for acute pain, avoiding invasive procedures, sucrose pacifier, local or topical anesthesia. This is where the evidence is the strongest. For postoperative pain, a short-term opioid therapy, some positioning, removal of surgical drains, using adjuvant drugs, things like that would be the most beneficial. For inflammatory pain, we should use the anti-inflammatory agents and consider opioids not as the first line, but as an adjuvant. And then for visceral pain, there are some other methodologies for which the evidence is not very strong. So I'll move from preventing pain to defining wellness and promoting wellness, because I think the balance should be more towards wellness and resilience rather than trying to prevent or fight against sort of diseases. So in terms of this is not taken from anywhere. This is just, and certainly many deficiencies may be, but in this, a state of physical well-being, physiological homeostasis, nutritional adequacy, emotional support, a sense of security, responsive caregiving, like Morten talked about, peace, social consistency, stability in the parenting that the child is receiving. And when this ecology of early life, the social ecology of childhood, gets disrupted by early life adversity, that's what determines the direction of illness to wellness. Because adversity leads to disrupted neurodevelopment, like Heidi Els pointed out, to social, emotional, cognitive impairments, adoption of health risk behaviors, and disease, disability, and early death. These are the mechanisms by which, adverse childhood experiences have an impact for the entire lifetime. And we actually published this in more detail in an article that just came out late last year. The science of development, early childhood development, is now coming of age. And this is Maureen Black's paper in The Lancet, where she talks about, she and the entire committee put together this model of, how there is a multi-generational life course of development, health, and well-being, and how this plays out through preconception and pregnancy, into parenting and caregiving, the newborn and early childhood period going on through the later childhood and up to adulthood. And at each of these stages, the human being has certain developmental goals. And in order for them to reach their developmental potential, the most important component is nurturing care. Loving, nurturing, and that nurturing care involves, health promotion, nutrition, security and safety, the responsive caregiving, the receive, take, and give back. And this whole cycle of, which is a joyous cycle between the caregiver and the baby, which is what prepares the child in the best state for early learning to happen. So that's what I'd like to focus upon. We have three brains. We have a reptilian brain, which is mainly involved in survival. This evolved about 500 million years ago, and is responsible for our vital functions and things like that. And then we have a mammalian brain from about 200 million years ago. And that involves the limbic system. This is mainly to do with feelings, relationships, nurturing, images, dreams, and play. And then finally, the executive part of the brain, the human brain, evolved about 50,000 years ago, including thoughts, planning, language, logic, and will. So this is part of the prefrontal, the white areas that were somehow non-sensory areas. So this is the part of the brain that really needs to be built, and this has been talked about in various different articles. This is the part of the brain that we need to empower and nurture in the early caregiving. One of the ways we can do that is through kangaroo mother care. And I'm sure you've seen this randomized control trial of survival of infants with low birth weight with kangaroo mother care. This occurred in many of the, totally in developing countries, and the results were quite astounding. Through this very simple intervention, there was increased survival. There was reduced hypothermia, reduced sepsis in the early period, and other outcomes that were fairly significant. So what does kangaroo mother care involve? It involves skin-to-skin contact for thermoregulation, for proprioception, for nurturing and nutrition. All of those things are facilitated through kangaroo mother care. KMC also reduces mortality, sepsis, readmissions, apnea of prematurity, prevents hypothermia, increases breastfeeding, growth of the brain. And so there's been a few meta-analyses, improved self-regulation, improved cognition, motor skills, etc. So not only are these outcomes in the early infancy, but also later on, it promotes longer preschool attendance, less school absenteeism, and things like that. So this brings me to the question of how do newborn infants actually learn from the environment that they've suddenly been enclosed in the mother's womb, a very protected environment, and this is mainly through relationship-based activation of the multisensory input. The most active sensory systems in the newborn period are visual, auditory, tactile, and kinesthetic. Those are the four most important, most active senses. The smell and the taste, those will come on later. But this is where what the infant is using to interact with the universe that they've been born into. And in these interactions are caregiver competencies which have to figure out what are the infant's sensory needs and perceptions and relate to them. So that will occur through bonding in all routines of the child's development. And it occurs through opportunistic play, opportunistic interactions. And I have a video trying to explain that a little more. But this is a give, receive, take, and return response. These healthy cycles, go. The infant gives some signals, the mother receives the signals, responds, and returns to the baby, and this goes on, back and forth interactions all day, every day, from 0 to 3 years. And this is what will impact their domains of learning. When we are speaking with the babies, we don't speak the way I'm speaking right now. This would put a baby to sleep. And I'm surprised it isn't doing that the same to you. We say, hello, how are you? You've got blue eyes. So this language, it can be in any language, but this is what is called parentese. And the proportion of time that the child gets exposed to parentese, Patricia Kuhl showed that through a little recorder attached to the baby's shoulder, that proportion of time during the period of like 6 to 9, 10, 12 months will determine the child's vocabulary at 2 years, 3 years, and 6 years. This is how important that back and forth interaction is. We have, as pediatricians, we have focused mainly on assessing babies through motor development. And we know motor development proceeds from head to toe. The eyes, the neck become more active, and then, the arms reaching out and things like that before the baby learns to walk. But by the time the infant learns to walk, its senses and emotions have already adaptively learned to either withdraw or connect with the environment through the senses. And how does this happen? I beg to submit that this happens through one main phenomenon, and that's called multisensory integration. Multisensory, the social interaction between parent and child, between caregiver and child, is how all the senses come together to make each interaction into a learning event. The infants will recognize the message using all 5 senses. The child has to accept these messages. 3 or more senses will receive information, and recognition happens when all messages are merged into one learning event. If this is not pleasant, then that emotion is not transmitted to the executive brain. Therefore, there is little opportunity for learning. But if it is pleasant, if it is hedonistic, then the child will gather that information and use it as an opportunity to learn. Part of what comes about is through proprioception and vibrocochlear perception, the positioning. When would a child pay most attention to to music, like the music that was, if you have speakers either at the 3 o'clock position or at the 10 o'clock position, because that's how the child's vibrio-cochlear perception is organized in terms of its environment. Unfortunately, we have been late in recognizing this phenomenon. And now we are learning that the inadequate multisensory integration is a core deficit, which is part of autism, language delay, ADHD, socialization problems, many other developmental disorders. And this comes through this there are now 5 studies showing that the number of hours that a child is exposed to an electronic screen in the first year of life has a direct impact on the likelihood of autism being diagnosed at 2 years, 3 years, and 5 years of age. So I think it's very important for that social interaction to occur. I don't have a slide for this, but there was a randomized trial where babies in Washington State, in California, in the US, were taken and exposed to a language which is completely different from their spoken language at home, like Mandarin. So these were babies from English-speaking households. And half of them had interaction with a native Mandarin speaker who, taught them some Mandarin. These were babies between 6 to 9 months of age. And half of them had the same person on a tablet, and they were giving the same information. Those who had the social interactions retained that language and had orienting responses 6 months later, a year later, whereas those who were in front of a tablet with that same speaker's face, relaying that information, had no recognition of those Mandarin words. So let me just, can you play this? Okay. Ooh, what did I do? I love being with children. That's what motivates me to come to work with enthusiasm. And I've done this for 40 years. I'm concerned as a pediatrician about the incidence of autism, ADHD, development. Okay, maybe I should go back. Here you go. I love being with children. That's what motivates me to come to work with enthusiasm. And I've done this for 40 years. I'm concerned as a pediatrician about the incidence of autism, ADHD, developmental delays, and disorders that has been increasing, particularly from marginalized communities. Our project will eliminate these differences. We will approach pregnant mothers to follow them and their children up to their 5th birthday. We will teach about the baby's brain and show them how they can use the auditory, visual, tactile, and kinesthetic senses to connect the brain cells in a proper hierarchical way and build the child's multisensory integration. Like, for example, if you're changing the diaper on a baby, you talk to the baby, you make eye contact, you stroke their belly, taking their right heel to the left shoulder, helps to connect the 2 sides of the brain. This will give these children a greater edge in terms of their cognition, behavior, and will build a protective shield of resilience around these children, families, communities, and nations across the world. So, as we encourage the parenting practices to involve multisensory integration into every interaction, we help this child to overcome the difficulties in their environment. And as we know, this was an article by Amy Arnsten from Karolinska. Stress weakens your prefrontal networks. And she showed how there are insults to higher cognition. But if uh, in the normal, nurtured, healthy child, there is a top-down regulation of thought, action, and emotion um, uh, without the presence of early adversity. But if there is early adversity, then there is this reflexive and habitual responding by the more primitive brain circuits. This is where the reptilian and the mammalian brain have, free rein, and the prefrontal cortex, gets shut down or set aside for other things. When this is severe, then it leads to what we've termed a clinical syndrome of nervous system dysregulation. So this study came out of 100 patients we had seen in the clinic. These were all 5 years and older. They had 4 or more unexplained symptoms for longer than 3 months. So we assessed these children in the 6 functional domains, and we found that a lot of those children had somatization, sleep disturbances, emotional dysregulation, executive dysfunction, etc. The children with with the higher symptoms had 4 or more ACEs, and a higher median ACE score, 3 versus 1, as compared to the other children from our clinic. So this is clearly something that has, when there are adverse childhood experiences in early childhood particularly, it leads to this cascading cycle, and this kind of illness has only been described in Gulf War veterans, where they have this chronic multi-symptom illness with no pathological, reasons. No testing can show that. We were asked to outline, what are the pathways from ACEs to nervous system dysregulation, and came up with this model of, resilience versus adversity, where your neighborhood effects results from your environment, your social situations and structures. Community assets result from these social situations and economic conditions, healthcare access, etc. All of this is necessary for healthy growth and development. And this can lead to health-related behaviors, psychological, physiological adaptations. When these support systems are disordered and are associated with adversity, then instead of resolution, restoration, you get behavioral dysfunction, immune disorders, CNS dysregulation, and presentation in various kinds of physical and mental illnesses. Once we had completed the study, against this backdrop, we were all exposed to the COVID-19 pandemic, which had a huge impact on children. 1.5 billion children were confined to their homes. They had a loss of social activities, peer support groups, greater exposure to whatever was happening in the household at that time. Parents also experienced stress and burnout, social isolation, and there were sharp increases in physical, emotional, sexual abuse, increased call volumes to national abuse hotlines, and fewer options for any positive childhood experiences for children. So we have a measurement problem. It's relatively easy to measure the outputs, but how do we measure the inputs, social emotional inputs in this vulnerable period, particularly through, for nonverbal subjects who may be coming from unpredictable environments and have unreliable historians with them? How do we find time-scaled objective measures that are relevant? So we thought negative experiences may lead to stress, causing cortisol release. Positive experiences may lead to oxytocin release. So then we were stuck is there any relationship? It turns out that oxytocin is a neurotransmitter in the brain, which has a very strong negative downregulation of your HPA axis. This is the neurocircuitry that we published about 6 years ago. It inhibits both your anterior pituitary as well as the signal from the pituitary to the adrenal gland, and thereby limits the cortisol release over and above the negative feedback loop. So then we were stuck with this timescale problem. You give a baby a shot immunization, and cortisol increases, peaks at about 10-12 minutes, is gone by 20 minutes. You give a baby a hug, and baby releases oxytocin, but in about 3 or 4 minutes, that oxytocin has disappeared from the saliva, from the circulation, etc. How do we assess those experiences over weeks and months? That's when I hit upon the idea of what about measuring hormones in hair? Because hair keeps growing 1 centimeter a month, approximately. We only had adult data at that time, but since then we've published linear hair growth rates in preschool children. And what we've done is we've developed novel sensitive assays to measure hair cortisol and hair oxytocin. Our hair cortisol methodology was published a few years ago. It's now being used by at least, the last I counted, 15 different labs across the world, and they're publishing, results with our methodology. Have not published the hair oxytocin assay. We're just waiting for a patent on that one. So this is one of our first studies on what are the factors associated with hair cortisol. This was done in Memphis, Tennessee, where we took children at 1, 2, 3, and 4 years of age, CVs for clinic visits, and we measured hair cortisol. And of course, there's a drop between 3 and 4 years. This is when the negative feedback loop matures in the child, from the cortisol back to the pituitary. There were no differences in boys or girls, but we found in Memphis, Tennessee, we found big differences between the races. So these are, the white or other race children. These are the black or African American children, and there was, no change or no decline as was expected in early childhood. These are density plots at clinic visit 1, 2, 3, and 4 years of age. It shows a very different population. We also published our oxytocin concentrations at 1 to 4 years. And although there was no change across childhood, we did find some differences with higher levels in boys than in girls, as well as higher level in the white and other races as compared to children from the black races. We plotted out because we're measuring these two hormones in the same sample, the same protein extract from the hair shaft is used to measure these samples, we can do a molar ratio, which is what this plot looks like. But when you plot it out as a frequency histogram, it seems to follow a normal distribution. More work is continuing on this. We've now done about hair cortisol in over 2,000 children, and about 1,200 children we've done hair oxytocin levels. And what we found is in our studies is this decline in the hair cortisol levels, as we had noted earlier, which is slightly different in girls as compared to boys in terms of the trends. We've also found, some changes in hair oxytocin, higher levels in the younger infants, and then declining during early childhood to just the preschool age groups. In multivariable linear regressions, we found that hair cortisol decreases with age, which is something that is expected. But we also found that increases with the parents' hair cortisol. So if the parent is stressed, the child is going to have chronic stress as well. That is something, a new finding. Also, it was correlated with the child's ACEs scores, which was an important finding for the first time. In terms of hair oxytocin, if the parent has a high ACEs score, then they have less warmth in parental caregiving and there's a lower level of oxytocin. It was lower in the Hispanic ethnicity, but increases if the parents are rating the child's health and wellness as higher. So we have an objective biomarker now for being able to follow wellness in children. So this got me thinking, as if we can measure oxytocin, which is a nanopeptide hormone, without denaturing it, we were able to extract it from hair. What about the other proteins? We know that scalp hair is very different as opposed to hair anywhere else in the body. It's derived from the neuroectoderm and mesoderm. It monitors biorhythms. There are the anaphase, the cataphase, the telophase of hair growth, mirror the biorhythms of the body. It's a privileged immune environment, has many perivascular immune cells. It's a neuroendocrine monitor. All the three types of metabolically active cells, the striated muscle, the smooth muscle, and the fat cells, they're all located close to the hair follicle. So it monitors metabolism. There are 9 types of stem cells located in this part of the hair follicle. And by the time the hair comes out of the shaft, all of these cells are dead. They're all keratinized cells. But it samples the skin-related microbiome and the environment as well. So to summarize, it's a physiological monitor, but it's also a chronological record of what's happening elsewhere in the body. Hair contains, for the most part, a lot of proteins, and cortisol and oxytocin are bound to those proteins. It has been used for various monitoring of drug exposures and toxins. But when we look at what are those hair proteins, that data is simply limited to adults, small sample sizes, and all they focused on is keratins or keratin-associated proteins. We started to look at non-structural proteins that are present in the hair shaft. And this got published in January this year, where we had this study where we had normal healthy children growing up in their families, 32 of them, and 8 mothers. Each of these 8 mothers had 2 children in this cohort, and there were 16 unrelated children. We found higher protein spectral counts and numbers of proteins in the mothers as compared to the children, shown in the pink. We also found that there was, we did Spearman rank correlation. So here's a heat map of the correlation matrix. And based on these correlations, we were able to calculate Euclidean distances, showing that there are relationships between pairs of individuals in our group, creating this dendrogram where most of the mothers are located in this yellow branch and the younger children in this green branch, whereas the older children are in those 2 other branches. We then did this study to disregard the species of proteins, and we did these Boolean distances, the Manhattan distance from Boolean hair profiles. We found that they were much shorter between mothers and their biological children, as opposed to mothers who were mismatched with so they're not related to those children. So we found between mothers and their biological children, there were only about 200 proteins that were different. And as you get the mismatch, you have this null distribution of, through simulated data sets. Using the hair proteins, we could predict the age of the child with a fairly good classification of 93%. And the top 5% of the proteins that were contributing to variability, we found that they were associated with brain development, associated with cellular metabolism, as well as immune responses and regulation of stress-related pathways. So I think we have a window into the brain, particularly, and into the systems of the body. From our protein library, we cross-referenced 191 proteins are expressed in the brain from these two atlases. And so this gives us a non-invasive, painless way of looking into the brain of these children, by measuring their protein profiles. We've confirmed these through various ELISA assays. We also found 610 of these proteins are associated with signaling in innate immunity, many of which are expressed sporadically in individuals. I'm going to skip some of the other things. We found several histones in the 3,000 proteins, and come straight to this model. So basically, what I'm trying to convince you is that adverse childhood experiences or positive childhood experiences interact with parent-related factors, social drivers of health, to produce early life adversity, which can push the child into survival mode processing through toxic stress. This can cause HPA axis dysregulation. We've shown that in another paper published last year, which then has an impact on their social psychology, where early relationships with food, emotion, recognition, communication, and identity formation are affected. And so this leads to, problems during later childhood or emerging patterns of outcomes during adolescence and adulthood. This is just a more detailed map of, positive and negative factors that are promoting either typical behaviors, regulated emotions, executive function, social relationships, versus atypical behaviors, ADD, anxiety, emotional dysregulation, and those are related to different adult outcomes. So I would like to conclude, this universe is an infinitely vast, incredibly complex factory, which is designed and constructed to manufacture only one product, this entire universe. What is that? You're right. That is the entirely what is, and this has been recognized by poets and by artists, but not so much scientists until recently. Love rules the court, the camp, the grove, and men below, saints above, for love is heaven, heaven is love. Going from I to we go from illness to wellness. Through overcoming our egocentric approach, being able to connect with others. And this is not just important in the caregiving, but in all of our relationships, in all of our interactions. I was playing with this 9-month-old baby who had come to me in septic shock and multi-organ system failure. She was intubated, she was on pressors, etc. Now was off the ventilator, was ready to leave the ICU, and I was just playing with her. And her mother said, "Thank you for taking care of my baby." And I told her, no, you got it all wrong. Your baby is taking care of me. And so in this interaction, in the subject and the object, both disappear, and only the caring remains. Only the loving, nurturing remains. So who's giving the care, who's receiving the care is irrelevant. And that's how we can promote wellness, by allowing, and this is what will allow the human part of the brain to control the mammalian and reptilian parts throughout the lifespan. Multisensory integration, early learning can happen only during pleasant, peaceful, loving interactions between caregiver and child. And perhaps hair biomarkers like the rings of a tree may serve as a biological records of the changing seasons in life. Thank you very much for your attention.
Thank you so much. I'm sure there are plenty of questions, and we have time for them too. There's one.
Hi, I'm from Karolinska and the Nurses Aid. And you mentioned this with the signal and response, and let me see the last one, the 3 green dots.
Yeah.
But how much do you think it's important that the baby can serve itself? Like the older baby wants to choose, it doesn't want to be in a space where no toys, it doesn't want to have to ask. I'm thinking when the infant is on the parent's body, it can serve itself safety, oxytocin, going to the breast, it doesn't have to signal, because the parent can be a bit slow often in responding. How important can that be for the protective of adverse experiences, childhood experiences?
Yeah. I think it's an important question, which really we need to sort of think about. Like Heidi had pointed out, the behavior is always there. So there will be aversive behavior, or there will be, open behavior, receptive behavior that the child is saying. And I think the way Professor Kringelbach is doing is teaching the parents how to recognize and respect and honor the baby's wishes. That is what is important. So there are times at which the baby needs to conserve its energy, because the demands of growth and development are huge energy requirements for that to happen. But there are times when the baby is ready to, interact and connect with the environment. And I think the importance in our caregiving practices is if we learn to interpret those signals.
Thank you. I'm looking around for more questions. While we're waiting for one, may I place a question? There were certain common denominators in your 2 speeches here. You pronounced the term love. And you were discussing pursuit of happiness. I was just thinking, just struck me, the Swedish society, where we're right in the midst of just now, is an extremely secular society. So a huge proportion of people, of parents, lack, should we say, a spiritual framework with potential assistance in theoretical models related to concept love. Mm-hmm. Is that something you've been struck by? Should we say degree of spirituality, degree of religious diversity relative to the notions you're talking about?
So, very important, very thoughtful question. I think the key issue here is that to be able to differentiate very clearly between religiosity and spirituality. There is the screen of consciousness is the screen on which the entire universe is playing. There's a play of energy and matter on the screen of consciousness. As long as we are focused on the images, we don't see the screen. But once everything shuts down, then that pure consciousness is still there. So various masters and messengers have come and tried to relate us to that. I don't know where my consciousness ends and your consciousness begins, you know. And that's what is brought into play in this intuitive caregiving that Morten talked about, which every parent learns. And so it does not require the framework of religion with its dogma, its doctrines, its rituals, its ways of doing things. And I think there has been much unhappiness caused because of those. Because when you draw lines in consciousness, you say, okay, this is my religion, this is the boundary. Then there are some inside and some outside of that. So for me, I feel, the concept of God, you can give it any name, label. Those are just labels. The concept is an unconditional love, which is clearly a component of every religious doctrine. And the concept of spirituality boils down to simple being able to overcome my individual selfish needs, to be selfless and to be of service to others. So that's my very simplistic idea, which I feel we can all coexist peacefully. Even though we may follow different religions or we follow different cultures and faith traditions and so on, we can still learn to make sacrifices for each other and be of help to each other.
Thank you so much for those thoughtful reflections. I think we can thank you.
Thank you.
With a similar good round of applause.
Thank you.